I'm Kevwe Okoro, Health Economics Lead at Health Innovation Manchester. I'll be presenting the health economics results for the CHESS Troponin project on behalf of Miriam Chikunbanje, who is unfortunately unwell today. She's been responsible for conceptualizing and building the model. The presentation focuses on the economic evaluation of introducing ambulance-based troponin testing for patients with suspected NSTEMI and what that means for cost, capacity and resource use across the Greater Manchester health system. I'll start by briefly setting out the system problem we're trying to address, then moving through the evaluation question, the pathway change, and finally the results and implications. Chest pain is a high volume, high uncertainty pathway. Large numbers of patients flow into expensive acute settings because diagnostic uncertainty is resolved relatively late. That uncertainty drives inefficient resource use, for example, ambulances conveying patients just in case, emergency departments absorbing large volumes of low-risk patients, which results in capacity consumption before risk is fully understood. Importantly, costs and benefits fall in different parts of the system. Ambulance services, hospitals, and the wider NHS experience impacts in different ways, which means decisions taken in silos risk underinvestment in interventions that are beneficial overall. This is why system-level evidence is needed to inform adoption decisions. So the aim of the evaluation was to assess the system-level cost impact of ambulance-based troponin testing for suspected NSTEMI patients. Specifically, we estimated total NHS cost from paramedic arrival to emergency department discharge, comparing the current business-as-usual pathway with a future pathway using pre-hospital troponin testing combined with TMAX. We also explicitly looked at where costs fall and where benefits accrue across ambulance services, hospitals, and the wider NHS, because that distribution is central to how this intervention would be implemented in practice. So all of that leads to a single evaluation question. Does introducing ambulance-based troponin testing represent a cost saving or value for money pathway change for the NHS when costs are considered across the whole system? So this wasn't a clinically focused study or a procurement comparison. It was more focused on decision support analysis intended to inform whether this pathway change makes sense economically at a system level. Our focus was a system-level economic analysis to inform whether the proposed pathway change represents good value for the NHS. So on this slide, the lower orange portion of the decision pathway represents the proposed ambulance point of care testing. Patients attended by paramedics with suspected NSTEMI receive a troponin test and TMAX risk stratification in the pre-hospital setting, rather than waiting until arrival in the emergency department. Based on risk, patients may be safely managed at scene, conveyed to same-day emergency care or the emergency department, or directed to specialist care. A proportion of patients still require inter-facility transfer, which is reflected in the model. And the key change is earlier risk stratification, not a fundamental redesign of downstream hospital pathways. At a high level, this pathway from the previous screen change leads to two main impacts. First, reduce patient flow to the emergency department, generating both cost and capacity benefits. And secondly, reduce conveyance, including fewer interfacility transfers, which saves both time and cost. These impacts are what drive the economic results you'll see in the next few slides. So the base case results show that introducing pre-hospital troponin testing is cost-saving at a system level. In Greater Manchester, this equates to a net NHS saving of around 1.1 million per year, or £144 per patient. Hospital services account for the majority of the benefit, with annual cost savings of approximately 1.2 million, although the ambulance service incurs an annual cost of around 110,000. This investment is outweighed by savings across the wider system. The pathway also reduces emergency department time, particularly for high risk and very low risk patients, improving flow and patient experience. So the modelling approach was a high-level ex-ante model that was developed. It was structured as a decision tree with system-level costing combined with a patient-level micro-simulation. The model represents 7,916 Greater Manchester chest patients attended by paramedics with end-STEMI impression. The analysis takes an NHS perspective, comparing business as usual with pre-hospital troponin testing over a 7-year time horizon, reflecting the device's lifespan. So key data sources that informed the analysis was a combination of local service data, project data, and national NHS cost sources. This includes NWAS data on eligible population and conveyance rates, published evidence on TMAX risk distributions, project-specific troponin cost data, and NHS cost collections for emergency department and same-day emergency care and ambulance activity. I'm not going to go through this line by line, but the key point is that the analysis was grounded in real service level data. The key assumptions underpinning the analysis were first that beyond emergency department discharge, patient pathways are assumed unchanged. And then pre-hospital troponin testing was assumed to have comparable performance to hospital-based testing, and invalid tests reverted to the business as usual pathway with no repeat testing. Finally, there was no negative impact on patient outcomes, and earlier diagnosis was expected to be neutral or beneficial, particularly for high-risk patients. These assumptions were also tested in sensitivity analyses. So we tested the results under a range of alternative assumptions to assess their robustness. Across all scenarios examined, the overall conclusion remains unchanged. The pathway continues to deliver a net cost savings at NHS level in Greater Manchester, alongside consistent reductions in hospital costs. The main source of variation related to the ambulance service impact, reflecting operational factors such as time on scene and how the pathway is configured. Taken together, the results indicate that the economic case for earlier risk stratification is robust, with system-level savings maintained across a range of plausible assumptions. I'll now show how the sensitivity analysis, how sensitive these results were to changes in key cost drivers. So we explored how sensitive the results were to changes in key cost assumptions using a one-way sensitivity analysis. Across all scenarios tested, the intervention remained cost-saving, as said previously. The results were most sensitive to the number of ambulances equipped, rather than the 15% device price discount. The troponin test cost per patient included the device, consumables, QA, QC, and personnel, and the discount applies only to the device component. And then finally, we also ran a probabilistic sensitivity analysis, varying all parameters simultaneously. Now, most importantly was that across 10,000 simulations, the intervention was cost-saving in 96% of cases, with a mean annual Greater Manchester NHS saving of around 1.1 million. So this gives a high degree of confidence that the base case results are robust to uncertainty. So for the ambulance services, we see cost savings from fewer conveyances offset by increased costs from troponin testing. Overall, this results in an annual investment of around £110,000, alongside a net increase in time on scene driven by the testing. This reflects a shift in where resources are used rather than an inefficiency. And then for hospitals, the picture is clearer. Reduced emergency department attendances generated around 1.2 million per year in cost savings, with substantial time released, which was approximately 15,000 hours per year, which represents a clear capacity benefit for acute care. At a system level, the intervention remains cost-saving in all scenarios. NWAS was shown to attend around 590 fewer patients per year, which was driven by increased time on scene associated with the troponin testing. At the same time, emergency departments gained capacity to see around 2,780 more additional patients per year. Overall, as said previously, this culminates in a saving of around 1.1 million per year for Greater Manchester, and up to 22.5 million per year across England. Thank you.